Hey, everybody, welcome back. I just wanted to give a thanks and a shout out to myself for that last lecture. Buddy, I think you did a good job. Please put in the chat box below what did you think about the COVID 19 lecture that you just heard? But listen, make sure that it's all positive. I can't wait to read them. So, our first case here, this is a hyperhomocysteinemia case. We have a 30-year-old white male with a past history of ADHD, depression, anxiety, and hyperlipidemia. His father is alive and has obesity. His mother's alive and has depression and hyperlipidemia. His paternal grandfather has obesity and heart disease. So you see, obesity kind of runs in the family. His maternal grandfather has obesity and diabetes. So this guy, he just really has those metabolic syndrome genes. Chief complaint, fatigue for years, and it responds very well to Nuvigil. History of ADHD, depression, and anxiety with a good response to pharmaceutical medication. So, going through the questionnaires and the lifestyle, the bottom of the matrix questions, his sleep, 8 to 9 hours every night. He wakes up feeling refreshed, so his sleep seems good. Movement, he weight lifts 5 days a week. He does cardio 30 minutes 3 times a week. Nutrition, he's currently on a high protein, low fat, low carbohydrate food plan. He works really hard to go against his family's genes of diabetes and obesity and whatnot. Stress and relaxation, he's a high paced manager. He socially will drink beer every other day, really not much, one or two. He'll smoke a cigar maybe 2 times a week, but he doesn't inhale. That's important. Relationships, he lives with his fiance. He's in a good relationship. Spiritual, he really doesn't have a spiritual involvement. He doesn't really practice anything or do anything to connect. Medication and supplements, he's on vitamin D, omega-3s, a multivitamin. He's on a probiotic, and he takes alprazolam for as needed for anxiety, venlafaxine, armodafinil, or that Nuvigil. And his food plan is the carbohydrate restricted food plan. So taking a look at his timeline, he was bottle fed. Now, when you do these cases, I always want to start with, were you a C-section or vaginal birth? And he was a normal vaginal delivery. Why? Because if they were C-section, they have a higher risk of dysbiosis. And then I also ask about bottle fed and or breastfed, because bottle fed also increases dysbiosis, which disease starts in the gut. It can cause mental issues. It can cause we know that the gut, that if you have dysbiosis, it can cause all kinds of neurologic and physiologic problems. So age 6, he had low concentration, and he was diagnosed with ADHD, and he was started on a stimulant, which he thinks worked well, helped him with school. Age 16 to 18, he had irritability, he had a kind of a depressed mood, and he was diagnosed with depression, and his stimulant was changed to an SSRI, which might have helped him a little bit, he feels. When he was 24, he actually before his 24, he started to binge eat a little bit. He was promoted to pharmacy manager, which was a big step for him, a lot of pressure. So he started binge eating, and he started getting these anxiety attacks, and he was started on this PRN alprazolam. So he was started on this benzo to kind of help him with the anxiety. Age 25, his blood started showing that he has higher blood sugar in his diet, and that's why he started a low carbohydrate food plan. Age 27, he was feeling tired, and they changed his medicine. They went from a SSRI to venlafaxine and armodafinil. His current concerns is he gets this hyperglycemia, he has hyperlipidemia, depression, anxiety, fatigue, and the anxiety and fatigue is controlled on his medication, but without the medication, he would have them. So now, looking further, his vitals were fine. His blood pressure is a little bit in the pre-hypertensive range. His BMI is high. Looking at labs, so labs were done. He had the MTHFR gene mutation, the C677T. And remember what that does is that makes it harder for you to convert your methionine to, or I'm sorry, your homocysteine to methionine. So because if you can't work the methionine synthase, then you kind of get stuck with a higher homocysteine level. And look at his homocysteine, it's suboptimal. It's at 11. His insulin's high, his free fatty acids are high, his uric acid's a little bit high. So what biomarkers are we looking at? Insulin, high uric acid, his ApoB was elevated, his small density LDL was elevated, he has had a low omega-3 index on his labs, he had elevated LFTs, and his homocysteine was high. So you're taking a look at all this and trying to kind of work on this and put it all together. So clinical indicators is he has an elevated BMI and a family history of obesity, but we did a BIA and the guy had muscles. So the conclusion was that the high BMI was driven by his muscle mass and he didn't really need to lose any fat. He just needed to maintain. So initiate. We increased his omega-3 because his omega-3 level was off even though he was on some. We put him on a methyl vitamin, which had activated B6, activated B12, activated folate, and activated riboflavin, which is riboflavin 5-phosphate. So he had the MTHFR gene mutation in homocysteine, which makes you think, okay, he's missing methylfolate, but might as well, there's a lot of supplements out there that have a mix, might as well add some other methyl factors. And we did. And what was interesting is that he came back and his homocysteine was down. I'm like, all right, well, that's great. It looks like your methyl supplementation was helpful. His insulin went down a little bit. I mean, you can't really say too much from a 10 to a 9. And the interesting thing is that he was extremely excited because this is the first time that he'd been off his medication in years and felt great. So he actually went off of his meds. So a year later and follow up and actually now it's been a couple of years and he's still doing great and he's still not on any medication. So what happened here? So he ended up with these methyl factors, and the methyl factors, yes, it helps change his homocysteine to SAMe. But what does SAMe do? SAMe helps you with your neurotransmitters. It helps tryptophan become 5-HTP and serotonin, and it also is going to help tyrosine to become dopamine and norepinephrine. And if you look at the medication he was on, we were trying to modulate those neurotransmitters, but he was just missing methylfolate. So what do you do when you have a patient with methylfolate? What is my approach? First of all, the goal. There's different information out there in functional medicine. We don't always go with what the lab says is normal. We go to more optimal levels, and there's certain biomarkers that someone else may call normal, but we're like, nah, let's get it up a little bit higher. But the goal, a reasonable goal for homocysteine level seems to be up around 7. We kind of start with the bottom of the matrix. If you work on exercise, if you work on stress management, if you work on all of those things, if you learn nutrition and get those vegetables in, work on all of those things because you may see some shifting just doing that. Now, this patient was already doing a lot of the things that he should have been doing, and this is really where the methylfolate comes in. I myself have the MTHFR gene mutation, yet it's very rare that I would take methylfolate because my body does the job, and if I'm doing okay, I'm doing okay. And there's certain times where I'm getting stressed or I'm not taking care of myself, and I need to give myself a little supplementation. So, but we don't want to just put them on supplements forever because of their genes. So we're working on the bottom of the matrix. You could just put them on a better food plan and say, well, check your homocysteine again. You don't have to right away jump in and treat that, by the way. So with MTHFR gene mutations, if they have that, so if someone has high homocysteine and they have the MTHFR gene mutation, so if you haven't checked it, go ahead and check it. Remember the two, C677T and A1298C. Take a look and see what that status is. So if they do have the gene mutation, consider then throwing in some of the methyl factors, the mixed methyl factors. So you get the methylfolate and some other methyl factors as well. If your biomarkers look like they have oxidation or toxicity, abnormal liver function tests, mood disorder, lung issues, N-acetylcysteine is a great supplement. It increases glutathione and it may decrease homocysteine levels. Well, if they have inflammation, if they have oxidation, hypertension, anxiety, palpitations, and arrhythmias, well, guess what? Taurine might be a good thing because it helps with all of those things. If they have inflammation and low omega-3 levels, well, omega-3s can lower homocysteine as well. And if you have really resistant cases, well, then you can consider giving them trimethylglycine or betaine. Now you're going to watch TMAO levels, but if you remember what we talked about on day one, TMAO is more of a marker of or a indication that you have dysbiosis and you want to work on the gut. So I wouldn't necessarily not give trimethylglycine if their TMAO levels are high. You make sure that the person did not have fish oil for around 24 hours before that you do the test, and you also make sure that they didn't eat fish for at least 24 hours before the test, and then you work on their gut. So some people say, oh, your TMAO is high, so absolutely no betaine, no carnitine, stay off all that stuff, and just refer back to day one slides. That probably is not the case. Thank you very much. Up next, Dr. Saxena is going to rock this fasting lecture.